Good afternoon. Can you hear us?
Yes, I can hear you.
Yeah, fine. So let us go ahead with the case.
Okay, good afternoon, esteemed moderator, distinguished chairperson, panelists, and all our colleagues. Good afternoon. I'm glad to be here, and I'm Dr. Liu. I'm a cardiologist from China Medical University in Taiwan. I'm excited though to present a case with complex lesion today. Join me in this case lab is our esteemed colleague, Dr. Yang and Dr. Xie, and including I was in interpreter. And today we are looking forward to share our case in live demonstration in this complex case. Can we show our case? Yes, please introduce.
Hello, everyone. This is a case of a 74-year-old male. He has hypertension, hyperlipidemia, type 2 DN. About 1 month ago, he had sudden onset of dyspnea while traveling. So he came to our emergency department, and in our emergency department, acute pulmonary edema was noted, and also elevated cardiac enzyme was also noted. Next. This is his EKG. EKG show lateral lead ST depression. Next. The X-rays show pulmonary edema, and the RT CT show calcification from layman to LAD. Next. So we do the CAG for him. You can see we have critical lesions from circle ostium of circumflex to its proximal part. Several critical lesions, and it's already had CTO from the proximal part. Next, and also there's a lesion about 70% over the proximal part over the proximal RCA, and the PDA gives collateral to LAD. Next. So we do we deploy a stent from the ostium of circumflex to distal circumflex. Next. And this time our target is the LAD CTO. Next. Okay, next. Okay, so here's our plan. We plan to do a LAD CTO. We try to, our assessment is bilateral snap box approach, and use the dual injection to identify the length of the CTO. And we plan to try the anti-glare approach first with microcassier and the CTOY. If anti-glare fail, we might consider retrograde approach. And the image we plan to use the IVAS. And the bifurcation standing, we have to follow the IVAS finding to decide what kind of the standing strategy we use. Okay.
Okay, thank you. This is a old male with a complex lesion, and in previous PCI procedure, the LAD ostium was covered maybe by a few mesh of the stent from layman to circ. Hence, the LAD ostium was gelled. And we can see the proximal LAD is totally occluded. And here is today's angio. We do our procedure as our plan. We use a bilateral snapback approach with 7 French sheaths. And this is diagnostic caster. Is there any suggestion from the panelist or moderator? What can we do, or is there any comment for this case?
Yeah, so first of all, the lesion length appears to be between 10 and 20 millimeter. Is that right from what we see here?
Yes.
Right, and possibly there is one branch coming out in between the lesion. There is one diagonal branch coming within the CTO segment. Is that right?
Yes.
From what? Yeah, right. Yeah. And there is hardly any calcification over there, or maybe minimal calcification.
Yes.
Right? Yeah.
Yes.
I think anti-grade approach would be the right approach first. And going through the stent struts, you can pass a wire and a microcatheter. If you have any difficulty, maybe use a small size balloon just to open up the struts. And with the retrograde injection, try and see whether you can. And it looks as if the anti-grade approach would succeed from this, it looks like.
Yeah.
Of course, we have to see that this side branch looks to be fair size, I would say. Not a big size, but a fair size. So if we can preserve that side branch, that also would be an additional thing. If you try and fail, then maybe we have a good retrograde collateral also. Yes. From the PDA. And that also we can try in case if there is any problem with the anti-grade approach and we fail to go ahead. What do you say, Dr.
Okay. Okay, thank you very much. Okay, and this is the this is Wataru Nagama speaking from Japan. So, and from the JCT score is here just only the classified issue have. So maybe the success with from the anti-grade guide wiring. But for this case, and already the big shown I mentioned about this CTO exit have the very important bifurcation. So this side branch diagonal isn't so a big one, and this part is very difficult to see from the RCA. So anyway, maybe we have to keep the this big side branch diagonal. And if we pass through this bifurcation, I mean the distal CTO part, maybe the literary the procedure manner is very suitable for the keeping this bifurcation. From the APC to club algorithm, and if this CTO exit have the important bifurcation, the recommended the retrograde. It seems like this chapter 1 is like a very nice one. The very nice score is CC2, like a branch like. And from our J channel score is very quite low. Maybe the successful with the guide wire is maybe the excess 90% from our study. Thank you.
Okay, thank you. Thank you, moderators. I think that the difficulty we face today is the CTO. The lab bifurcation issue may be not quite difficult. As we didn't do a dual injection in previous procedure, we thought that the CTO is straightforward and go straight, and we can go down to the LD. However, today we face a difficulty because there's a big angulation from the diagonal LD branch and enter the LD. So today we try many times for integral approach using several guide wire. Initially, the wire go outside of the lumen. However, fortunately, maybe you can see what we do in the next procedure. Can we go forward?
Yes, please go ahead.
Yeah. Okay. I think this is another view. We can see there's also trifurcation, maybe trifurcation lesion regarding to the big ramus or maybe proximal OM between LAD and the circ. If we do the stenting, maybe we will lose the big ramus here. Maybe we can change another view, lateral view. You can see the lateral view. Okay. Okay. So today we use the bilateral snapback approach with 7 French. The left man was properly engaged with EBU 4, but EBU 4 was not can go directly to the engaged left man because the tortuosity of the aorta. And we changed to EBU 3.5. We can finally engaged, and we use the initially we use the diagnostic SAL guiding to engage the RCA team. This is our initial approach to test the track of the CTO. This is a run-through wire. We face much resistance, so this is true CTO without channel. And to facilitate the device crossing the stand cover on the ostium of LED, we use a small balloon dilatation, the LED ostium with 2.0 balloon, and to open the LED ostium. And then we bring down the microcaster Corsair Pro, and we make a tip injection. However, there is still no integrated microchannel. And this is our first while using field XDR. We go forward maybe easily, but if we show the retrograde from the we can see the frontal view. Can we see the frontal view? Initially, we are happy to see this picture because we fortunately enter the Truman. But in the lateral view, we can see the lateral view, spider view. Wire bias to other side. So we know this very tortuous lesion, CTO lesion here. Okay, we tried many times. We failed. So we moved to guide second and go directly according to the spider view. We can see the cascade straightward to the CTO lesion. We use the guide second wire and advance slowly, maybe made a progress, and we need to approach the bifurcation of the LED and the diagonal. Maybe we can move to a frontal view. Okay. We almost reached the CTO proximal, but I don't know. Can you see the angulation between the CTO lesion to entering the LED? Maybe it's difficult to see the lesion.
We can see that. We can see,
okay.
and we can see that your wire slightly has buckled at that place.
Yes, okay. At this moment, there's a sharp angle to go straight forward between the LED diagonal and go down to the true LED. There's a sharp angle here. So we have to make a big turn using the wire deflection, maybe deflection property, and to go down. But the wire can go smoothly. So we use a guy next to make a third attempt. We make a progress very soon because the penetration power of guy next to. We make a progress, but from the other view, we can see we can see the frontal view. The wire is maybe entering the lumen, but in lateral view, spider view, the LED is go down, sharp angle, sharp turn. So we change the projection to LL view next. Check view. Okay. Okay. So we can see. Can you see the wire deviate out of the lumen? In the frontal view, the lumen is parallel to wire. In this view, it failed. So we have a lot of struggle here because the wire go outside of lumen in different projection. So we make several attempts. And the wire goes to the diagonal, but can't go back to LED. After several attempts, fortunately the wire go into the LED. But you can see the lateral view. Lateral view, the wire still go out of the lumen.
Yeah.
Yes.
Yeah.
At this
so
moment,
can you stop for a moment here?
Yes,
can you
okay.
stop for a moment here? So we have a question here. Many a times it so happens during the CTO procedure that your wire goes into one of the side branches. Maybe it is septal, or maybe it is diagonal, or in the RCA, maybe it is one of the branches. In that scenario, would you like to just pre-dilate that so that at least the proximal part of the CTO has opened up? You have a channel going into the side branch, and sometimes there is some antigrade flow into the distal portion of the CTO, which guides you where to put the wire. Would that be a proper step? Or as you are doing just now, you remove the wire from the side branch and now going into the distal portion of the CTO. What is your view and what is Professor Maramatsu's view?
Okay, thank you very much. Okay, and so once the given the ballooning, so this procedure have the possibility in the created dissection, and once the take out this guide wire, and this the next step maybe some have the possibility going the CT guide wire going to their dissection space. So basically, I think if this guide wire wants to the side branch in front of the CTO, we have the good option that using the dual room microscope. Yeah. And for the nicer backup force. Yeah. So actually, this lesion is quite short. Maybe we don't need to extend to the single room microscope. Yeah. This is the one option.
So what's your opinion about using a dual lumen catheter when you are in the side branch and then use lumen?
Very excellent suggestion. So from the beginning, maybe my wire go to the diagonal. If we can make sure the track to AOD from CTO to the diagonal, maybe we can open that channel and use dual lumen catheter. At this moment, the wire bias to the subintimal space very early on. We can see the frontal view. Can you show frontal view? Yes, we can see the wire deviate outside of the lumen. Because there is a sharp turn of CTO go down to the AOD, this is a sharp angle. And from the lateral view, we also can use a very sharp angle to go back to the lumen. So we change the wire direction. Once we can go to the diagonal properly and making sure that the lumen is the diagonal. Maybe we can use this policy. And after several attempts, the wire still outside of the lumen. We can see the lateral view here. And other view. How about this view? Can you, is that true lumen or not?
If you can stop here, we have a question for you here just now, both to you and our expert over here. At what stage would you go ahead with a parallel wire technique? At what stage would you stop and say, okay, now I try parallel wire technique or a retrograde technique? Because some people do not like to go to parallel wire if there is a retrograde possibility. Professor, what's your view?
Okay. And it looks like a very struggle and when you use their Gaia next to and so this is time to switch to the another manner like retrograde.
Yeah, because I see at least this wire has gone at 3 places. Maybe there is hematoma by this time. You know, once it went laterally, another time it went medially, when it went superiorly. So, Professor Liu, what's your take on that?
Yes. As Dr. Curti mentioned, we have entered the diagonal, just like this view. Can we see the frontal view?
Yeah.
The front, yes. After entering the wire, I tried to bring down the microcatheter, but I have tried to draw the blood from the microcatheter. There is no blood here, so I'm not sure whether I'm in the true lumen. So I give up the plan and pull back the microcatheter back to the CTO. And I try again to use the wire behavior and make a deviation bring down the wire. Maybe the wire can still go outside the lumen, but after several attempts, several trials, I use a different direction. There are many dissection channels, so maybe a dual lumen parallel wire technique is a good choice to let a previous wire in there to show the subintimal track and use another wire to use to enter a different direction. But if the proximal AOD is very small, or there's a big angle, maybe or cascading, maybe the second wire or second microcatheter cannot be bring down smoothly.
So do you have recross catheter over there, double lumen catheter? I mean,
yes, we have lumen catheter. We have Sasuke. We have
you have the recross.
Recross? No, we don't have recross. And we have Crusade and Sasuke microcatheter. We can see lateral view. Can we see the lateral view? Okay. Could you have any suggestion here? If by the lateral view, do you see that whether the wire in the true lumen or not?
So I think the problem here is we are not sure whether we are in the vessel structure or not because we are using very penetrative wires like Gaia. Okay, so the first choice would be me exactly the filter XTR. You have done that, but filter XTR you are not going outside the vessel. So somehow, if you would catch something inside the architecture, then we would have the chance to have a parallel wire technique or something. I'm still in this case using a penetrative wire and trying to divert them into the lesion is very, very difficult. And we have very doubt that we are actually in the architecture or outside the architecture. So it's very difficult to understand. My suggestion would be here, either go with a dual lumen microcatheter and then changing to a polymer jacketed wire and at least, or penetrating from the beginning again with a polymer jacketed wire with the filter XDR at least to see being in the architecture for sure 100% and then going over that with a polymer jacketed wire and then going then with a Gaia with ultimate or something. But polymer jacketed wires should be here very helpful in terms of that.
Okay, it's a very good suggestion. And by this view, we initially think we are in the false lumen because there is a parallel lumen on the near the tip of the wire. But from my tactile feeling and the frontal view, I think maybe the parallel lumen comes from the septal branch. Maybe we still in the true lumen. So I decide to bring down my wire, and unfortunately the wire goes into. So from the different projection, maybe some branch will make a mistake to let you thinking that you are in a false lumen. After placing the wire using Gaia next to, unfortunately we enter our wire distally. We have already for bailout retrograde approach, the guiding caster, the 150 centimeter microcaster. Unfortunately, we don't have to use that retrograde approach. Then I bring down my wholesale pro and make a tip injection, and make a balloon dilatation here, and do the IVUS. I think the critical point to use the dedicated integrated wire is use the wire property because the sliding cannot control the direction. But the Gaia next to have the X1 design, we can use the deflection power to use the wall and to deflection our right tip. And unfortunately go into the true lumen. And is there any suggestion or we can see the IVUS here?
This thing is that, if you continue to, create more and more dissection planes, then things become even more difficult. So at least my tendency is to use parallel wire at the very, beginning, so that, in an already complex situation, by creating more dissection planes, you make the situation even more complex and the chances of failure increase. So parallel wire technique may be used in, at a, relatively earlier stage. That's what, because in this case you are lucky. I mean that you are already in a very big branch.
Yes,
I believe it's in branch.
I'm very lucky. Very lucky.
So yeah. But it's extraordinary. So this category is Caravelle, I believe. This is micro category is Caravelle.
Okay, right? This is a Corsair Pro.
Okay, Corsair Pro.
Corsair Pro,
okay,
yeah,
okay.
yes.
Yeah.
Then now I was here. As you mentioned, that's very.
Professor Leo,
yes.
If I can interrupt now, can we go to the other lab by the time you
no
finish
problem.
and then show us the
one moment.
the IVUS?
Do you have any suggestion from the element bifurcation stenting technique? Q-load or tap or other suggestion from the distinguished panelist or moderator or chairperson?
We should first gain the diagonals back, so we need them to enter. And these diagonals are not to be, unlooked for. So we have to enter the diagonals with some safety wires. Maybe you need some dual lumen for that. And then after ballooning, maybe after IVUS and aggressive predilation, maybe at the ostium, a draw cathode balloon could also be a solution. But after having an aggressive predilation, and this vessel is for sure I haven't seen the IVUS, but what I am seeing here is it's like the angiography. You know, we have calcification there. And
Yeah.
this calcification need to be modified with any scoring or cutting balloon. So that's what I do. I would do, preferably at the proximal part, I would do aggressive predilation and then would see the flow. Even I would have considered doing a drug-coated balloon at the ostium and preventing any complex procedure if it's possible after ballooning.
Okay, good suggestion. Thank you.
Yeah. Yeah, so we go to the other lab and we leave it to you if you think, because for culotte, I think your vessel size it should match.
Okay, thank
On
you.
the IVUS, it does appear that the LED vessel size is quite big.
Yeah.
And so hopefully you should be able to match that to make it a culotte, or else if you have to do a T-stenting or something like that.
Oh, thank you.
So we go to the other lab by the time you finish and we'll come back to you.
I'll see you.
So we go to Japan now with Professor Kashima there. Are you ready, sir? Professor Kashima and Dr. Kuramatsu from Sapporo Cardiovascular Clinic.
Can you hear me?
Can you hear us?
Okay. So, of course, thank you so much for inviting for us. We are very waiting for a long time. So today's, I'm Yoshihumi Kashima, and so I have today's great staff, Kano Sensei and Matsuda Sensei, and so my super expert rotablator nurse and medical engineer, and also Kuramitsu Sensei. Kuramitsu Sensei, please share today's case.
Okay, so thank you so much, Kashima Sensei. So can you see the presentation slide on your screen? Not yet?
Not yet.
Okay, please switch to the case presentation slide.
So we can't see the slide.
Yeah, I know. So
you can
that's
go
why-
ahead with the history. By the time we can see the real angios, what's the procedure going on?
Okay, yes. So, of course, I had that, and so today, so my procedure time is and so less than 30 minutes. So we have to prepare, so simple case, but of course, hard calcification. You can see that, so today's angiogram. Can you see?
Yeah, but
Can you take the picture on the big screen, please?
yes, and it's still small the way.
Yeah, the angio picture is too small.
Yeah, we
Oh, okay, so
keep it
please
flat.
change
Can you shift it to the main?
large angle.
Yeah, now we
now-
can.
now it's okay.
Very
In
good.
big
Now we
screen.
are.
Okay. So you can see angio shows us and so severe calcified on the so proximal LAD. And also, that stenosis in the looks 75 to the 90% around the diagonal branch. However, so we already did an FFR. So Kurami Sensei, what is FFR value?
Okay, so actually, so angiogram showed a 75% stenosis at mid LAD. So that's why I did physiological
90s.
assessment so before the PCI. The FFR is 0.94 at the distal LAD, and the largest step up is observed at mid LAD. So that's why today target the mid LAD, the region.
はい、ダイナ。
Thank you.
ワイヤーが抜けてるわ。
So the FFR is 0.94 if we get
7-4
74. Okay.
at distal, and
もう一回ダイナ。
the largest step up is the mid LAD from 0.80 to 0.98.
Okay, and we can share the indication.
So you are going ahead with an elective rotablation procedure before you do the imaging. Is that right?
No. So actually, I have already performed the IBUS, so before rotablator. So that's why. So let me share the IBUS. So before rotablator. So
Yes, go ahead.
Can you see the IBUS?
Yes, and we can share the IVUS image
Yeah, if you
before.
can show
Okay.
us, it's fine. Otherwise, we'll take your word for that. Yeah, okay, fine.
Okay. So anyway, so due to the time limit, so I do the both IBUS and the rotablator simultaneously. And this is the IBUS finding. So before the procedure, and so this is a third diagonal branch. So we can see the superficial calcium, and this is the second diagonal, and we can see the almost, so could you click? So this is the second diagonal, and we can see the almost circumferential calcium, so before the second diagonal. And looking at the wire bias, I mean the location of the IVUS catheter can help the wire bias. So that's why please take a look at the IVUS catheter location. And so, you know, the wire bias, so very good. So because IVUS catheters attach the calcium.
Okay, and we
Do you
can see
think
wire
there is a
bias.
suggestion of a nodule over there?
Oh, no. This is not nodule calcium. So
If you
actually,
can take
the
that on
seed
the
calcium.
big screen, on the big screen, the IVUS picture.
So
Yes,
please.
Yeah,
Okay.
and then we can see the continuously that this guide wire bias from the 0 to 3 o'clock. And maybe touch where is the classifier matter. Yeah, that's good.
Thank you very much, Nagama Sensei.
Kashima Sensei, thank you.
Hi. So already explained that. Okay. So now I make and so 1.75 rotation with and so 180,000. But and so this calcification so very hard. So now still I rotated it. This part very hard. You understand? Sound is much different. Okay, but already passed through that. Okay, next, so please, 息を吸ってもらって。はい、please, deep breath, stop. Okay, so passing a root ablation, passing at once, but you have that, so still ablation sound there because I use and so respiration bias now. So respiration bias always so we need and so cooperation with the patient. So I said to the patient, please deep breath, then stop, then root ablation, and release this. So now I make it.
This is a very interesting, good technique. And change the intentionally to change the wire bias and using
Yes.
the patient deep breath.
Yes, exactly. So sometimes so when you cannot advance and so balloon, then sometimes you use this technique.
Yeah, and especially using the middle part of the RCA. Yeah.
Yeah. Okay, so 2 over, please, 2 over.
So do you believe in doing a
Tosho-san.
rotational speed rotablation after you cross the lesion? At,
Yes, of
say,
course.
From 180 to 120 or something like that, just to
No. So,
lumen size?
of course, more than 10 years ago, I recommend the slow speed rotablation instead of the polishing run. But so currently, little bit change. Because 10 years ago, I said that 100 to the 120 is better. But after so 5 years ago, I evaluate the a lot of IVUS image. Then so if we set more less than 140,000, sometimes bar makes a vessel injury. Of course, without perforation, but in some injury there. So I have never used so less than 140,000 after that. いいよ。19万。
So what's your minimum speed then?
Yes, 140,000. So, but in this case, I don't need so low speed rotablation with 1.75 because today my strategy is so using 2 bar, 1.75 and 2 over. So if so 2 over is success, then of course I use so low speed rotablation. But okay. Always I use, okay. Okashi, stop. Sorry now and so some trouble happened. So rotablation console is and so cannot work well. So now we changed the new one. Please wait a moment. So now I show you the IBUS image after the 1.75 rotablation.
Very interesting.
Yeah, that would be good. And please show us on the large screen.
Yeah, large screen, please,
Yeah.
for IBUS findings.
So just for the sake of audience, if we get it right from what you said, if you are using two burr technique, that is you are using one smaller size and a bigger size, then low speed rotablation possibly is not required because you are going for a bigger size burr.
I put it back.
Maybe.
But in India, we don't have the luxury always to use two burrs because of
Okay,
cost
that's only the
constraints.
one.
Yes, of course. So I understand. I have a lot of procedure in any country. So of course, if you can use only one bar, you have to make so rotablation afterwards for safety. After that, you can make so low speed rotablation, of course, and other technique. Then you can get so a large acute gain. So please explain the IBUS findings after 1.75. Kuramichi sensei.
はい、OK、鹿島先生。OK、so can you see the IBUS? And so this is the IBUS after rotablate 1.25,
回転した？
1.75, okay? And so this is the diagonal and the calcium so well ablated, but we can see the calcium still there. And of course, so we already check whether the basic injury so occurred or not. So looking at this IBUS findings, there is no basic injury so far, and also calcium is well ablated, but still there. So that's why Kashima sensei decided to perform to all rotor bar.
いくよ。
Okay.
OK、ダイナ。
Okay, and how about the bias? Is still okay?
Thank you very much. So looking at the wire bias, and
A little bit change comparing the previous image.
Yes,
Now,
little bit change.
more correctly, 3 to 6.
but I think the wire bias looks nice. So
Yeah.
After
Still
the
nice,
rotor
still
blade with 1.75, and that's why I think so we can perform rotor blade safely and effectively.
So Professor Kashima,
Yeah.
what is your threshold to use IVL here? Instead
So-
of going to a 2-0
Of course.
rotablation, which is a bit more aggressive for people like us, then in this case we would have gone ahead because there is still one arc of 270 degrees calcium left behind. There is one shot where there was 270 arc of calcium without any crack. Yeah, there.
Yeah.
IBL
I
cannot
think
all. Yes.
That situation, I mean, if I had the luxury of going to IVL, I would have gone for an IVL.
Okay, and this is a good option, but maybe that we have to care about the side branch. Yeah, please remember that this lesion have the side branch, big diagonal, and this diagonal, the also part have the lesion. Maybe the much more or less the calcium part is much better for the keeping this bifurcation.
Yes, so exactly. Nagama sensei, thank you so much. Nice your comment. So of course, IBL is a very useful device. However, IBL always never promised and a good result always. It's problem. Nobody knows when IBL failed or not. So always we need cracking before, the rotablation, volume reduction before cracking. It's important. Then so we can make easily crack, making the crack with IBL and cutting button. Definitely, it's an important point. So there is no history. So to conquer the calcified region with only cracking technique. So always we combined two techniques, max.
Yeah, this might
Right.
show
So
now.
I think for the audience, you should remember Professor Kashima's name in case you are not a proponent of IVL and more proponent of a rotablation. So you always have one argument with you.
Yeah, quite large.
Yeah, so let's see with your 2 millimeter rotablation.
Okay.
Very nice. So looks like the patient status is still okay. Very nice.
Yes. And so you show that, sorry, a little bit so ST elevation. So I use and so nitroprusside now. If you don't have a nitroprusside, of course, you can use an epinephrine cocktail. So if you use and so nitroprusside 30 to 60 microgram per times, and if you use an epinephrine 5 to 20 microgram per times to prevent the slow flow and so improve and so slow flow. It's an so tip and tricks for root ablation.
In our country, we use
Now already improve and so ST elevation. So of course not completely, but and so just end of the so this procedure, ST elevation is and so recovered.
Yeah, so I think
I never
some
stated
amount of hypotension also, maybe slow flow also.
micro.
In the perfusion fluid, do you add nitroglycerin there?
No, nitroglycerin for the so large vessel, middle to large vessel. So I always use a nitroprusside.
So maybe
What
that-
about nicorandil? Do you use nicorandil? over there?
Yes, so nicorandil is also effective. But in the so nicorandil is in the so my second line. Because and so nitroprusside and epinephrine is and so much effective compared with nicorandil. But also, you know, as you know, nicorandil can affect and so acute and chronic. So if so slow flow, TIMI2 and less than TIMI2 flow, so TIMI1, TIMI0 happen, of course you should use and so nicorandil. It's important. So now I finished and so 1.75 and with respiration bias and the 2O root ablation already done. So I show you and so IBUS imaging findings after 2O bar.
So what is your preference between OCT and IVUS, especially in calcium lesion? You are using IVUS here. I mean,
Yes.
you would have thought that maybe OCT would have shown us a better.
Yes, very good question, suggestion. So, but in the so I always use an IBUS all cases in complex because OCT always required blood flushing the blood pressure, removing the blood pressure. If a dissection happen, flushing is so not so good behavior. So I don't use an OCT for complex case, especially the so calcified region. So of course I know OCT shows us the thickness of calcium, but you know thickness is not always hardness because the calcification always different component and different density. So sometimes we OCT and CT tell a lie. So I always use the so IBUS because I want to check and so how to rotablate, how to cracking during the procedure. So IBUS always can show us any findings for many times. Please.
Okay, so this is IBUS product after 2O
Yes, very nice.
bar.
Okay.
And the calcium is well aberrated compared with the previous one. And also, we always check whether the basic injury occur or not. So at the proximal part. And
okay,
so
please explain. Okay.
Let's review the IBUS quickly. And so this is a difference, vessel difference site. This is a fourth diagonal branch. And the distal landing zone, so here, after the fourth the diagonal branch. And looking at the more proximal part, so this is a calcium. So, you know, the calcium is aberrated and more proximal, you know, the calcium, the lumen diameter one over 2.1. It means, you know, calcium is well aberrated. And looking at the more proximal part, we can see some crackle, so after rotablators. And this is a diagonal. Okay, so anyway, so I think the rotablator can work well. So looking at this I was finding. So thank you very much.
Yes, so to tell the truth, actually, so I want to use 2.25 bar for this case. In Japan, it's so available. However, I know a lot of country less than 2 bar isn't available. This so in the rotor ablation. So today I show you the so less than 2 bar rotor ablation. Because 2 bar in the so 7 French acceptable 2 sorry, and the wire twist happen.
Okay, and after that, giving your 2O number, and we can see the some kind of reverb from this second iris study. Yeah, we can feel there's some of the kind of the efficacy that you, and after that you perform in the 2O.
High inflation, 468. 14.
So what size balloon is this?
This is a 3O cutting balloon, 10 millimeter. You have in the 10 to the 15 cutting balloon, 2 types, 40. But and so I always use the 10 millimeter cutting balloon, 20. Cutting balloon for calcified region, and sometimes with high pressure. Now 14 to the 20 atmosphere to cracking. Of course, in non-calcified region, I always use less than 10 atmosphere. So much different usage. これ20? はい、デフレ。Now 20 again.
So is this Wolverine or some other
Yes,
brand?
Wolverine, 20.
Yeah.
So, but then, so you already show that, and the 20 atmosphere 3O cutting balloon, still not completely dilated.
No, so there is a waste there. There is a waste there at the bifurcation.
Yeah, it means so. Okay, if we don't make the rotor ablation, of course we cannot achieve it and so complete result, high deflation. So always volume reduction required before the cracking like this, high inflation, 20. High deflation.
But I think by using cutting balloon, any NC balloon will crack further. So you have
no need, because down.
So if
compliant balloon cannot work well in this situation. So of course, sometimes good, but not always. Because and so conventional balloon has only 4 mechanisms: compression, redistribution, vessel stretch, dissection. However, you know, calcification cannot, and nobody can compress. Nobody can distribution. So always balloon mechanism, 40. Balloon mechanism is and so dissection and so vessel stretch. So no need. Okay, now completely dilated there.
Yeah, gradually.
Yes, now it's better now.
Yeah.
Okay, check one at the moment. Okay, very nice.
Yeah. Good. So, Professor, we will leave you here and we go to the other lab and come back to you by the time you finish. That would be nice because we have only 10 minutes left now. So we go 5 minutes.
Okay, no problem. Remaining my procedure only stating.
After 5 minutes, we come back to you. Is that
okay, please go ahead.
Thank you very much. Thank you.
Thank you.
So we go ahead to the other lab. Right. And let's see, Professor Leo, where are we now?
Yes, thank you.
We have 5 minutes with you now.
Okay, we have a little progress here, and we put a 2-wire, one to LOD and one to diagonal. And we can see the diagonal flow is very poor. Once we stand from approximate LOD to mid LOD, maybe the diagonal will be jailed. So we use the balloon dilatation here to open up the important diagonal, long diagonal DB2. We can see the approximate LOD is a very big dissection. We forget to see the IVUS. Can we show the IVUS after initial wiring? Can you do? Are you interested to see the IVUS? We can put the IVUS here.
Okay, the IVUS, we can see the middle LAD was relative plaque-free and the 2.0 millimeter as its diameter. And when it goes into the CTO part, here. There's a superficial calcification over there. And when it goes further proximal, we can see there's a hematoma. Hematoma over the 6 to 10 o'clock direction. But our wire is still in true lumen. And the CTO body, we can see the superficial calcification with the heavy fibrotic plaque burden over here. And when the IFAS goes to the near the ostium of LAD, the diameter is 4.0 millimeter, and also covered by about 180-degree superficial calcification. And when it goes to the distal lemon part, we can see there's not much protrusion from the circumference stent. Okay, that's the LED pullback. And here's the DB pullback. DB is about 2.0 diameter with also diffuse and heavy plaque burden. And when it goes near the ostium, we can see there's some hematoma near the ostium of the DB. Also the 6 to 10 o'clock direction. We also do a pullback of the circumflex stent. Let's emphasize the ostium part. Okay, the stent, this is a stent in the circumflex. When it goes near the ostium, we can see here. Okay, the LD wire goes in, so we can see there's not much protrusion of the circumflex into the lemon part. Okay, and this is the lemon. Lemon is about 4.5 millimeter as diameter, and the plaque burden is relatively low comparing to the LAD. Okay. Oh, that's the IFAS finding.
Yes. Fortunately, we can see that all the way down to the true lumen. We enter the true lumen without any dissection, but there's a big hematoma there. After we viewing the result of the IVUS and the image, we decide to use the bifurcation stenting in between diagonal LLD. Because there is a big dissection extending from the proximal part of LDDB2 bifurcation and extending into the DB2 ostium. So we put a cruise stent here. We can see the beautiful movement of the stent down to the LD distal. And we may use another balloon for crushing. Then we use mini crush technique to deploy the diagonal stent here and make a mini crush. And this is the result of mini crush. And we use another cruise stent here. Initially, we face a small resistance, but after repeat pushing, we can smoothly bring down the stent. And after proper position, we avoid the distal landing zone at the part of myocardium bridge. Then we deploy the stent.
This so what stents are these?
Yes, Superflex cruise stent.
Okay.
Okay.
So these are thin struts, ultra thin struts.
Yes, it's a very ultra thin strut stent. Yes, it's also from India, I think. I have many experience in using the cruise stent. I think the advantage of the cruise stent is that the crossing profile is very best in the class, and the pushability and trackability is also perfect. I use in the cruise stent in many complex stations, including bifurcation, DK crush, or culotte stenting. This is the initial result of our procedure today.
So, have you finished, or you will do some?
Yes, we should do some post-dilatation. Yes, of course.
And imaging, everything.
Yeah,
because we have finished our time schedule here for your case.
Yes.
And we'll go finally to the other case. But congratulations and for an excellent demonstration of a CTO antegrade approach. And we are thankful to you to show us live pictures from there. Thank you very much.
Thank you. See you. Thanks. Thank you.
Thank you. Bye.
Bye.
So we go to the other lab. Right.
Thank you. Come back to us.
we have 4 minutes left for your case.
Enough. I finished and so implant in the so
Yeah.
stent. So now I just and so IBUS imaging after the stenting and so post dilatation with and so 3.5 non-compliant balloon with high pressure. So please show that. Okay.
And what
Hi,
about
okay.
the
Please
diagonal
go
branch?
ahead.
Have you done any treatment for that?
Yeah,
Diagonal
no,
branch or
nothing.
Just,
Because the flow is good.
yeah, okay,
Yeah,
good.
very nice. Yeah.
Excellent, despite. And let us see now whether there is some under expansion at the site of the waist, where it was 270 degrees arc of calcium.
Okay, please explain the so IBUS findings. Kuramichi Sensei, go ahead.
Okay, so let me show the the final IBUS finding quickly. And this is the distal landing zone. So there is no stent apposition and edge dissection. And the stent is well expanded. And looking at the proximal, yeah, this is the proximal side. And this is now we can see the septal branch. So, fiber o'clock. And so actually, abortion is okay. There is no edge dissection. And regarding the bifurcation site, little bit difficult to identify it.
Yeah, maybe due to the crash fire part. Maybe
Yeah, yeah, you're right.
Yep.
I'm sorry. It's
Okay, just 2 minutes left.
Yeah.
Yeah, I know.
Last 2 minutes. And if you can show us the area at the site where it's a bit oblong.
Okay, so I will show you the MSA site. So actually, this software, so very nice to identify the minimal lumen site. This is the minimal lumen site.
Yeah.
So just
Wonderful.
proximal.
8.5 acceptable
Yeah.
for.
Yeah, area is 8.5 square millimeters.
Yes, so already you understand. So today I making the 2-0 rotabulation. So if without rotabulation and so only cracking technique, nobody can achieve this good result in this simple calcification region. So we have to make and always both combination. So and cracking and volume reduction technique. So this is the final angiogram, like this. Of
Yeah,
course,
so-
and already remaining in the side branch.
So, Professor, I think the IVL people might be disappointed with you. You must be using very little IVL with this technique.
Yes, actually, thank you very much.
Thank you very
Giving the
much for an excellent.
Thank you.
Yeah. Thank you very much.
Thank you.
For you. Thank you.
Very nice.
Bye bye. Thank you very much.
Thank you very much.
I think-
Nagamatsu Sensei,
Yes.
thank you.
Thank you.
Welcome.
We have finished the session in time. I think we are just left with 1 minute. And thanks to everybody.
Yeah.
And I think we had an excellent demonstration of 2 cases.
Yes.
One of a CTO, and that was through the stent
Yes.
with using the anti-grade approach.
Yeah.
Although there was hematoma, as we said earlier,
Very well seen
at the IVUS, correct. Yeah, so that's where some people prefer a parallel wire technique instead of that. But anyway, the end result was good. And the second was a rotablation case, which was quite nice. And we
Quite
could
nice. We
have
can
some
share
learning
the
points
technology.
from that.
Yeah.
That low speed rotablation with a single burr. And if you're going to 2 burrs, maybe you don't require that. And the way the case was handled, even with 270-degree arc of calcium without using an IVL, which is a very costly device for us. So
most of us would prefer to do a rotative in this case. If we have done a rotative first,